I would like to call upon the dais Dr. Seemantini Desai, Dr. Subramaniam Swaminathan, both of whom we have heard in the morning already. We also have Dr. Sandeep to join them on the dais. Dr. Sandeep is an infectious disease consultant and associate professor in microbiology at BJS Medical College in Bangalore. And also, I would like to call upon Dr. B.R. Saujanya. She is an assistant professor, Ramaya Medical College, Bangalore. Yes, the panel on microbiology was something that we had in mind because the whole theme of this conference was diabetic foot infection. And I'm sure that the panel would have thought of how they would want to use this half an hour with Dr. Seemantini and Dr. Swaminathan already setting the stage on fire. I just hope we don't require fire extinguishers. Thank you so much, and over to you guys. We will allow questions now. So I'm sure people who are interested in asking the specialists here on the dais about questions can do so, provided they do not interrupt what our specialists are speaking about. So over to you, madam.
Okay, here I am, Dr. Seemantini, Saujanya, Sandeep. We already finished our panel discussion in a group. We've come to one level and then we decided we'll discuss with you all. Actually, I took the liberty to present a case which I had dealt some time ago around COVID time. As all of you know, it's a chronic diabetes, otherwise healthy, hypertensive, lady patient from West Bengal. I live in Whitefield, so a lot of West Bengal patients. 6 to 7 skin grafts, large ulcer on the shin. Very, very rare that I found an ulcer which is on the entire of the shin, around 10 centimeters by 6.5 centimeter width. And she presented actually to the surgeon, plastic surgeon, frustrated, crying, depressed, saying, I would rather kill myself than undergo all these things. Why I was involved? Because my lab works like that. I take up a hospital and I give them complete microbiology solutions along with infection control. So they said, why don't you accompany me? She's very depressed. So come to the scene. I think you will see the ulcer I've drawn. Both me and my surgeon friend have lost all the slides that he presented in his plastic surgery conference. So I had to redraw. I'm an artist anyways. I have drawn this ulcer exactly like this. We drew it. We worked on it by drawing like this. I made multiple copies of it. I just said we'll charge her for one swab. This is what I said. Out of my interest, I said we'll charge for one swab. If they grow same bacteria, then one swab you'll pay. If they grow many bacteria, you'll pay for all of them. She agreed. So we picked up like this. There is a logic around it. I felt foot end and the distal and proximal, I took it like that. One which is close contact with the skin. Then I left 1 centimeter because why graft was failing? That was what I was thinking. I'm not a surgeon. I'm sure the surgeon is doing a great job putting the grafts. Why it is rejecting is all I'm looking at. So I thought maybe they are previous cultures, either Pseudomonas or MRSA, any one, never polymicrobial. So I thought, okay, let me try multiples. And this is what I do even for neurosurgery. I work for Satya Sai Super Specialty in Whitefield, where it's cardiac and neurosurgery. They're also, long chronic ulcers, wound, non-healing wound. This is common for us. When we did it, very surprisingly, can you see the amount of number of bacteria I isolated? E. coli, MRSA, cons, Pseudomonas, from very different spectrum on the same side. And as Subra said, I was involved, so I didn't do rolling of swab. I literally punched it. I asked them, give me a forceps. Just finish the debridement. Fifth in the line of cleaning was my swabbing. That helped me. And I went to the center thinking, why it is so red and healthy? Subra kept asking, is it healthy? I said, so normal and healthy. That's what I think that was the most deceptive thing for the surgeon. Healthy, lag raha hai, kahin se bhi le lo. Healthy, it is looking, I just took it from somewhere. And I think I discussed independently with the microbiologist and ID here. Are you involved at any given point of time when a wound swab is taken, from where it is taken, why it is taken, and opinion matter? Absolutely, I don't think Saujanya agrees. She says from the OT they send, ma'am. I'm very happy with the honest answer, but the losers are the surgeons. You include, anyway the service is there. Sandeep, are you involved in every surgery that goes through this kind of deal?
No, ma'am.
Yeah.
I am
But
involved
I am
only
involved
when
in
there
every
is-
surgery. Every surgery I am involved. Why? Because I approach. Every time there is a swab sent, I said, what case was it? First time they did a mistake saying that we sent it from this. I said, please draw and send. Oh, you're so diligent. I said, yes. Can you just allow me to help you so that you can help patient? Oh, you come free, right? Yeah, no consultation. That's when I was involved. In any medical college, I'm sure, you are all free, paid by the college. I think me going forth was my way of doing it. Probably it's good in the initial stage. From 2003 to 2025, I've seen it all, done it all. We have come a long way. Subra and me were talking. We have come a long way in infectious diseases. People have accepted having a microbiologist on at least hospital panel. At least hospitals want to have a microbiologist. Let the MSCs do their cultures. I'm not saying anything. If you don't think much, you will not give the results. Now here we are with this ulcer. We healed it. Third day, graft taken, no infection. Patient walked out. Even today, every Dashera, she sends me a small piece of soft copy of Durga on me. Okay? So she says, because of you, I am living normally. This is one happy phase, but being very attached to neurosurgery, as my husband is one neurosurgeon and spine surgeon. That's a sound for me? No. I do a lot of wound healing cases, and every time approach is not the same. Every ulcer is different for me. Because I stand, I think, I have to solve. And something clicks. I'm telling you, seeing a patient, it clicks. Your basic MBBS, take help. And definitely having an ID physician, my job, I'll give culture and I'll keep quiet, because no matter what I tell, surgeon never listens to us. Magnex Fort, 21 days. Why? That's how it is in osteomyelitis. Makes no sense. No. You leave that to us. No? You gave your culture, right? So I think ID helps. There are a lot of ID physicians in Bangalore. Subra also comes on Thursdays. And I'm just saying multi-speciality approach is the only way for DA. Okay? Now over to, first I'll ask my counterpart, who is also a microbiologist, who sent a swab. How do you report? When you come across in one swab more than 2 bacteria, do you withhold the report saying this is, you discussed with me that, ma'am, I think cons is a colonizer. You withhold the report thinking that it is cons and a colonizer, or you submit and expect the surgeon to discuss?
No, swab is not an ideal specimen, so even in case worst of the worst, even if it's accepted
Okay, let's
and
call it a
cons is
sample. Okay, let's call it a
it's
sample.
isolated. I would like to look at it more as a colonizer rather than a pathogen,
Okay.
and probably ask for another.
Okay, I
sample
would
of
like to
deeper
stop you here. Did you discuss with the doctor what is he expecting? All the organisms that I have isolated, shall I present to you? Then you take a call, or I'll withhold some report because I think it is colonizer. There are two perspectives. I've seen a lot of microbiologists tell me that colonizer क्यों दे रहे हो? I'm like, give it to the doctors, let them decide. Streptococcus pneumoniae in the vaginal swab. You call it a colonizer? I don't think so. Not especially for a normal birth of the baby. So I would give the report anyways. Let the surgeon take it a call, or let the physician call it. I don't think in the lab I should take a call, it is a colonizer. What do you guys think? You want a complete report, or you want some colonizer that I think, according to textbook, I keep it with me? What do you think? Subra?
So this is the time where our august audience can ask, or in fact tell them what they feel, because this is a leading question which Dr. Seemantini is asking us, that would you want the report to have every bacteria that has been isolated from the wound, or would you want to ask them specifically what is the one which is causing problem to my wound.
I think
Yes,
we
sir.
should have a show of hands.
Can we have mics please, because this has to be interactive.
Yeah, I'm Dr. Suresh, I'm a vascular surgeon. We see about 40 wounds a day in our clinic. Now, I appreciate what you said. Never assume a diabetic foot wound is monoorganism. No, it doesn't exist. Even in Western literature, about 82% are polymicrobic. Just because I don't grow it, don't report it, you never assume that. Now, having said that, now, is there a role for microbial gene analysis to see multiple organisms? Because there was a study, we did a study on that microbial gene analysis. The culture grew 1, and when we did a DNA analysis, the usually average was 4. I would definitely would like to have even the so-called colonizer reported, because I would treat that. We have a symbiotic bacteria, like Astobacter with E. coli. They cause a lot of destruction in the
Yes.
wound.
Yes. See, I don't know whether you want to treat it or not, but you should have the knowledge that it is there. What do you say, Sudha?
Fair enough. One of my professors in the US told me the word assume makes an ass of you and me. Never assume. Never assume. Always deal with facts. See, the problem is actually a little more than that. Let us say you are given all the organisms. Okay. I have a natural booming voice, but usually I don't even need a mic. All right, okay. Let us say Dr. Simanthini, she is giving you a report and there are 4 different organisms in that. The next question that comes up is, how do you choose what antibiotic to treat, and do you treat all of them? Do you treat some of them? Do you pick and choose what you want to treat? See, all these questions come up. It is a lot more tricky than that. I think there's a little more behind it before we go forward. I'll say that in a minute, but I think more answers should come from the floor.
Yeah, I think, see, treatment part we are going to go to the end. Okay, whether we treat or not, we'll come to the end. Here we are stopping exactly where a microbiologist is facing you guys, clinicians.
Dr. Ashu, yes.
Yeah. So we should never forget the basics, that what we have been taught in our graduation and MBBS days. Like infection is what a host responds to an organism. Then only it is called an infection, and that is truly by ruber, color and dollar. So I am being endocrinologist and teaching DM students in PGI. We teach exactly this, and then only we take cultures as tissue. So whatever is thrown back on me, I should not say thrown back, by microbiologist, that I am growing this. So I'll believe that yes, this is the pathogenic organism. But I never cut standard tissue if I'm not having a host response. Even if I do culture from my skin like this, it will grow something. It will always grow. And I believe that we have so many culture reports, pan sensitive, pan resistant. And I am really in doubt when I see pan resistant, and really in doubt when either my tissue or
I'm going to throw something back at you. Let's assume this, let us envisage the situation of a very bad diabetic who's a vasculopath and the neuropath. He has horrible autonomic neuropathy as well. You're not going to see all the things that you mentioned in full glory, even if there is an infection. See, I deal with a lot of transplant patients. They are a whole different basket of worms. So the problem is, while that is so for a healthy person, a lot of the people that we see are not necessarily that healthy. But it is overstated. Let me make this very clear. What I'm saying is a stretch. But there is a small subset of people where the typical signs of inflammation may be at best muted. So you're right. You're absolutely right when you say it's the host response to inflammation. But the problem is there are some hosts who don't respond well. They can have the inflammation. It's like advanced HIV and cryptococcal meningitis. The CSF will be dead normal, but they'll have cryptococcus, and it is an infection. So the problem is that how do you draw the line? I think this is where it has to be a dynamic decision making, where you look at overall how the patient is, and also the local syndrome, and then come to a conclusion slash confusion on what's happening.
Yeah.
To answer
So, yes, sir.
just to answer Madam's question of as a surgeon, I'm Dr. Srinivas from Apollo at Hyderabad. We are lucky enough to have a good, very aggressive ID team along with us in the same hospital. So I would like to have all the bugs that you grow up and report them to me. Go to the MDT, I discuss with my ideas which needs to be treated or which need not be treated, or what is a call we can take on it
I give
together.
you a big 5-star for that, doc. That's how the approach should be, is what I am feeling as a microbiologist, because I don't have time, but if I present you certain cases where I thought, my junior microbiologist thought it is, why are you reporting, ma'am? It turned out to be it was a lifesaver bacteria. You may never know. I am sitting in the lab. Today's microbes, every one of them matter. Corns have grown. Look at the resistance. Look at the candida that was missing in gram stain I never cultured it. Everything that is documented well, the surgeon will sit down. If the surgeon is called a microbiologist to do this work, he's smart enough to sit down, take a call, discuss, and then go ahead. This is what I feel should go. For DO, that's the only way out. Sandeep, I would like to hear you.
Ma'am, I am facing a different spectrum of the problem. The moment we give, I wouldn't say all the surgeons, but a few of them, or in fact for that matter even orthopedics, they are not well aware of the organism names. So they get very fascinated by these names and they pick and choose 1 or 2 antibiotics for each organism that is being reported. So the patient ends up minimum of 9 to 10 antibiotics which is going on with lot of drug interactions. One may work, one may not work, but still, and still the patient is spiking fever is what I get calls for.
I
So
think you are into ID, Sandeep. You should
Yes,
also
yes.
step into the same shoes.
yes ma'am, but it's a new setup in my college, so
It's
they're
much
still
better.
getting
Old setup is
used
so
to-
difficult. New setup, you put your foot down, is how I see.
Yeah, I'm doing that, but not many clinicians are aware about the specialty
Get
itself.
aggressive, get aggressive.
Yeah.
Just like the microorganisms.
Yeah.
Okay. So I will take that as a compliment what Sandeep told me. Sandeep is he's a classmate. So we orthopedic surgeons always believe that heart is just a pump which takes the antibiotics to the bones. So I will take that as a compliment. But Dr. Saujanya, I would want your take on, see, we as diabetic foot surgeons, we keep hearing that there are a lot of fungal infections which we are missing. Okay. Now, obviously, we all know, you people have already spoken to us as to what is the thing that you want. You do not want a twirled around swab, right? So we agree to that fact. But when do we send for a fungal culture? I mean, do you have criteria saying that, okay, this is when you look for a fungal culture? Because see, invariably, I will talk for everyone who is here. When we see a wound which has come to us, a chronic wound, invariably the wound would have gone to multiple places. He would be pumped with multiple antibiotics. He would have undergone a lot of stainings, lot of cultures, and then the patient would have come to me. So because I see that you are an expert in mycology, so I just wanted to know, what is your take on when should we look for a fungal, when should we send for a fungal culture?
One, diabetic ulcer being a polymicrobial and the patient being pumped with multiple antibiotics, probably that is one way of the mycotic, like the fungi, even if it's a normal candida per se, itself can flourish and can be a pathogen, especially in a diabetic ulcer. And like ma'am said, a simple gram stain will give an idea, though we might not be able to culture because already the patient has been covered with multiple antibiotics. It's very difficult sometimes for us, and the way the sample is given to us, and maybe the patient has a broad spectrum coverage. But then all of them should have an idea because the vascularity is involved, the neuropathy is involved, the multiple antibiotics being pumped, the patient might not even know, like, where he would have acquired the infection of fungi itself. So maybe a chronic ulcer, they should have a suspicion of.
So mind you, 85% of my patients, I see around 80 wounds a day. 85% of my patients are more than 3 weeks or 4 weeks old. So how many samples?
Won't give candida.
Okay, so so that's what we want to know. That's what we want to know from ID guys, that when would you want us to think of fungal Yes, Dr. Swaminathan.
So, again, another of my teachers said every tumor should be cultured and every abscess should be biopsied. Again, I hate the word assume. The point is, what is the gold standard for diagnosing tissue level fungal infection? The answer is histopath.
Yeah.
It's not culture. Culture will tell you what it is and how you treat it, but it does not tell you if there is invasion. And the word you're looking for
Yeah.
is invasion.
Yep.
So you need both. You need a sample to go to pathology, and pathology has to tell you, yowza, we got invasion. And then microbiology has a look at it. So in my hospital, what happens is whenever a sample goes to pathology and they find tissue invasion, please keep in mind that even for mold infections and aspergillus and things like that, up to 20% of the time, the pathologist is wrong in identifying the fungus. So our protocol is, if they see it, microbiology walks over to pathology. I have a very smart young lady who's very good at mycology. She looks at it and says, sir, it looks like this, but I am going to get a culture and I'm going to see what it is. So the answer is, send samples both to micro and path. Ask path if there is invasion. If there is invasion, you got a problem. Then you ask micro, tell me what it is.
So now, the next question that comes as a diabetic foot surgeon, how many samples do I take? 5?
See, it's not how many. You send a tissue, we
Yeah,
take it.
yeah.
You send a tissue, we take it. But
Okay.
two, different consult first. Look
Yeah.
at the wound, ask somebody else also to look at the wound. 2 minds work very well. 3, it's not a big deal. It's not expensive at all. Compared to your 5,000 to meropenem, I think cultures are hardly anything. A gram stain, she asked me, what about the QS? She gave me so many queries. I gave her all answers because I had done all that. But I gave only the positive history in this case.
Yeah.
Gram stain caught a lot of my, expectations. And then I knew what to expect in the culture. Some surprised me. Cons and MRSA I couldn't make out in the gram stain. They surprised me with 2. Pseudomonas was never seen. Such a slender bacteria I could never make out in the gram stain, but then popped up. E. coli was expected because I could see the typical GNDs. But all of us are not gods. Like you start imagining, then you are a fool. It's always seeing. And I always put SDA as a part of my wound culture in chronic ulcers. I just tell if it grows, maybe, I have the liberty to do it. Bill it anyway, it doesn't matter. It
Right.
saves you a lot of antibiotics and antifungals.
So now that we are at ISC, I hope Dr. Siddharth is here. Yes, Dr. Siddharth, that is something that we have to think about. So we are sending cultures, we are looking at cultures, how quickly we can get them back. Probably your team can help us there with that. So yes.
I'm coming to
We
that.
did, we did that.
Yeah.
Back to, see, you wanted to say something?
So one small thing, like Sir has mentioned, the sample has to be sent both to the micro and pathology. The only concern with this is, most of the time it's so believed that the surgeon does the surgery, the sample is sent, correct? But it will be sent in a wrong way, that the formalin is sent to both us as well as the
Yeah,
Very important
I know.
Something we are concerned about.
I know.
Absolutely important point.
Yes.
It has to be said 100 times. Thank you for bringing it
Yes.
up. So in our hospital, what happens is when the patient goes for surgery, we always send them a saline bottle,
Yes.
a sterile saline bottle and a formalin bottle, and say put one sample into both
Yeah.
and equal amounts.
Yeah.
What happens is they'll put a they'll cut off something, they'll put
Okay.
a line share in this, and then take a swab stick kind of equivalent and put it in the micro. Why?
Yeah.
Be nice. One other question, one other point. See, this is where again MDT will help. Ask the pathologist what it looks like. If you find granulomatous inflammation, it tells you different things. If you see fungal filaments, it tells you different things. If you're not seeing fungal elements penetrating in, why are you asking for a fungal culture? You understand? See, the problem is we want to tick off everything. But that's also a problem. Somebody sends a swab stick and they want 10 different cultures and 10 different PCR. You're looking like, what do you want me to do? You can't do any of this stuff.
Yeah.
See, the point is, if you talk to think of it as a frozen section. Ask the pathologist to quickly have a look at a gram stain. Tell us what it is. Then the microbiologist can tell you, listen, let's do these things. Otherwise, you're putting in a lot of resources, cost overruns come in, but it requires a little extra.
But Subra, in any case, if they send the tissue, we can put it in the fridge. Fungal culture can go
Absolutely.
on slowly.
Yeah, yeah.
Rest of them, whatever you want, can be done. I mean, based on
Dr.
the
Suresh.
If nobody is asked.
Yeah.
Now, one comment and a question. The comment is, with all this, don't forget the local wound care.
Yes.
I don't mean applying antibiotics, which most of the time is a no-no, the local system. If you auto debridement of the body helps, unless you debride properly, clean up. And we use a lot of ultrasonic cleaner, which is bactericidal, which kills the bacteria. Don't forget that. The question to the panel is, when you're multibacterial, do you do a quantitative culture?
Yes,
you have
yes,
10
we
to the
do.
power
We
7
do.
plus.
Yes.
If you don't have 10 to the power 7, should you treat it? And how much the systemic antibiotic works for local infection if you don't have cellulitis?
So, however quantitative cultures you do, my only question is if you are putting a graft, that one bacteria can be a nuisance. But you cannot create a no bacteria area at all in any graft, in any case, right? So, quantitation definitely helps. But aggression of a certain bacteria helps you more. Like MRSA is highly aggressive. E. coli can be Pseudomonas can be a just colonizer, but E. coli can be very aggressive. So if you understand that cons can be equally aggressive, my thesis was on cons and I had undermined it that's why I came so heavily on Sargenia. I always thought cons was just another bacteria, but when we went into it, we saw it was all over the place and nobody bothered even do the study. Most boring but then enthralling subject I had for 3 years. But cons did kill as meningitis, where they were injecting all the other things into the blood, and then I found they were dying in Imhans and also in Gulbarga. But understand, aggression of a bacteria matters a lot.
Yeah, still have not answered my question. How much is systemic antibiotic work?
We have
The
not yet
local
come to
way-
that, sir.
then-
Last
uh,
end part is what antibiotics were used to heal, whether we should use it at all,
Fair
and
enough.
why did the patient heal at all. I mean, there were so many other things that we did. We'll take it up in the last 3 minutes.
Sandeep, you have something to
Actually, for the quantitative cultures, what sir was asking, one biggest role for quantitative cultures is the prognosis of the wound. I mean, whether it's healing or not, that is where it plays a role. But initial diagnosis and treatment, I don't think it has much role for that.
I will provide the counterpoint to that. When you do quantitation of a non-sterile area, it all depends on how the sample is taken. It's like COVID PCR. If you did the sampling a little more aggressively, your PCR threshold will be higher, your CT values will be lower. If you did a bang-up job, then your CT threshold will be much higher, your numbers will be bigger. So the point is, it also depends on how you've taken the sample. So if 2 people take 2 samples, you may get 2 different reports for the same wound. So please keep that in mind. It's a bit of a problem because there's a lot of pre-analytics involved in this.
Yeah. If you consider the 5th stage as taking sampling, that is debridement, washing, all that, probably there the quantification still values.
Dr. Tushar.
Hello, I'm Dr. Ege from.
Yeah. Dr. Saurabh, please come here.
Yes, Dr. Tushar, please do.
Dr. Ege from Mumbai. It's an eye-opener. Probably never had so much exposure to microbiology. Asking a practical question, I get an infected wound, I debride that wound. I start on empiric antibiotics. You are just using clindamycin and piperacillin tazobactam. The patient starts improving. All his parameters start coming normal. WBC count normal, CRP dropping. Clinically, patient is fine. And I get the report showing resistance to both these organisms. I want the answer on 2 counts. One is practically what I'm supposed to do, and medico-legally what is correct in this case. Both the antibiotics which I'm giving are showing resistance right now. Patient clinically fine.
So in ID, we talk about what is called the 90-60 rule. 90-60 rule means if you have a susceptibility report available and it says the organism is susceptible, and remember that this you haven't factored in the PKPD for that matter. Like for example, you don't use aminoglycosides for bone because penetration is really bad. Let's keep that aside. But if you're using a susceptible antibiotic for an infection, the chance of success is about 90%. If you're using a resistant antibiotic, the chance of success is still 60%. It's not 0. See, the point is that the most important step, like he pointed out, is wound care and debridement. Antibiotics are only to give you a little extra. Antibiotics cannot replace good wound care. Let me make that very clear. See, since time immemorial we have had this. Antibiotics have been around for less than 100 years. People have been taking care of foot ulcers for God knows how long, leprosy and all that, we've had it. But the point is, people, it was not zero success. It's because good debridement and good drainage itself will count for a lot. So I think you're going to be fine. See, the problem is, when you use an antibiotic which you know is possibly failing, what are all the downsides? One, you can have a relapse of the infection, you can have complications, you can have worsening of the problem and things like that. It is okay to use it as long as you document it and say, since the patient is currently clinically improving, I'm going to watch this patient very, very closely, and if there is any change, I'm going to change to something else. See, ultimately the most important thing is what you want the patient to get better. It's not about, my feeling,
Yes.
this should be it, or that should
Yes,
be it.
yes.
It should be about the patient getting, if the patient is getting better, you know what, fine.
Yes,
Like
we were
continuous
taught about this,
The
that
patient
never
is
treat the
always-
reports, treat the
But
patient.
keep a close eye. This is the kind of patient where you'd say, you know what, if there is any funny business, again, I would still subclassify. In my transplant patients, I would not take that chance. Because their immunity is basically bupkis. So I have to provide everything with the antibiotic. So there I would say, I don't care what it is, I'm going to switch to the agent which I think is going to be definitely.
Last
Again,
1 minute.
Yes, we are going to
Okay.
take the last question by Dr. Saurabh.
Okay, sir.
Dr. Saurabh.
Can I conclude with what we did with this ulcer? Okay, we did nothing. Masterly inactive.
I thought so.
Yeah. Knowing all of that, like he said, we were ready with our weapons. Preoperatively, nothing. Just wound debridement, skin took well, ready. We pepped up patient's immunity by giving methicobal injections. We pepped her up vitamin Ds. We gave her high protein diet. Unbelievably, low sugars, good protein, no insulin, good correction of walking, stature, everything done well. It just healed. Unbelievably true, but I'm just trying to prove you don't need antibiotics even in the worst cases.
Dr. Saurabh.
So I am aware of the only 12 seconds are left for me. Two practical points I wanted to ask, especially from the other side. Very rampant practice, unfortunately, in India is still use of the hydrogen peroxide. Irrigating the wound with that, either purely concentrated, diluted, various forms with betadine, without betadine. For a microbiologist, does it make any difference in terms of wound culture? That's my number one question. And just for the time's sake, my second question is, what does the panel think about the application of local antibiotics, which is also very, very rampant in India? Does it help or does it produce more problems?
I would ask Subra to take, because cultures are going to be horrible with hydrogen peroxide around. Protein gone, nothing is there.
Any kind of pungent agent like that is also going to damage a lot of good tissue as well. The idea is, as a surgeon, you're looking at taking out as much bad tissue but sparing as much good tissue as possible. But this is like a bomb. It's like a carpet bombing the place, and that's not a good idea. Because
Sir,
you
is
want
there
good
any
health.
role of hydrogen peroxide in the
I
hospital
don't-
at all? Should it not be banned like sulfuric acid?
Sir, but
It's
that's
a
not,
good sterilant, sir.
Yeah, I mean, it's not my place to say that. There may be some chemical uses of it, but we don't use hydrogen peroxide in my hospital. I don't like that agent. It's way too scary because there's potential for risk for other people and all that, because the fumes can be dangerous. A lot of things involved in it.
Antibiotic in the local area.
Antibiotic in the local area, I'm dead against that. Why? Because, see, when you're thinking of diabetic foot infection, especially deep infection, these are systemic infections. You're thinking of osteomyelitis, which needs to be treated systemically. Just putting some stuff locally over there does not make sense. Second, there's a lot of colonizing organisms which are sitting quietly over there. You expose them to more antibiotics, you're making them develop more resistance. And God forbid they go in and cause osteomyelitis, you have now converted successfully from a easy to treat osteomyelitis organism to a horrible to treat osteomyelitis organism. So let's not educate the bacteria and make it a problem for us. The same thing happens with nebulized antibiotics as well. Both the European and the American guidelines have come out very clearly saying, please don't do nebulized antibiotics in the ICU and things like that. The same thing applies. Please do not use, please do not use topical antibiotics. They really don't serve any purpose.
Thank you. Thank you. Thank you to the whole panel. I know we might have many other questions. All the questions can be taken up with the panelists when they are free. So thank you once again, Dr. Simantini, Dr. Sandeep, Dr. Saujanya, Dr. Swaminathan.